Uh, so uh, Last Saturday we had an introduction to research methods and many things like variables and things like that. And I hope you were able to go through the PowerPoint presentation. Mm, And Welcome, Vinti. I'm not going to introduce you again because each one of them knows you very well. So, welcome, and it's over to you.
How is everybody today? Good. How many people do we have in this course otherwise?
The complete quorum
Uh,
25, ma'am, 26 to be precise.
Okay.
But I believe maybe most of them have not cut short, called it a day in their duty. So
Okay.
I think that they will be joining.
Okay. So any problems? I mean, I will start, but were you able to go through some of the stuff that we covered last week? Dr. Jagriti, I can't hear you.
I tried little bit.
Okay. So today we'll cover measurement, a little bit of data collection. Maybe we'll play a little fun game. Okay, let's see how it happens. Okay, and then slight introduction to some technical stuff. Okay, and let's see how it goes. Okay, so I'll just share my screen. I have. Okay, let me see. There is so much of my screen. Let's just shut this one. Save. Okay. Everybody can see my screen?
Yes, ma'am.
Yes, yes.
Okay, great. Okay. So we were somewhere here. So let's start with measurement rate. Okay, so today let's look at measurement. And normally we talk about measurement in terms of social sciences, but today we'll actually have a look at a small research paper. Okay, and so I'll share that introduction. And so we have decided that we're going to do 6 papers throughout this course, which was selected by Queen's College. So I'll just kind of introduce you to that paper, and then we'll take this measurement thing. Okay, so I'm just going to introduce you to that paper. Can you see my screen?
Yes.
Okay. So this is a paper which is on double-blind trial of haloperidol, chloropromazine, and lorapazam in the treatment of delirium in hospitalized AIDS patients. Okay. Now we will not get into the methodology aspect. Okay. But for me today, this paper was important because it was looking in terms of scales. Okay. And so before we actually went on to do scales, I thought let me just get on to you in terms of looking at what scales they have used, and then we'll describe it. Okay. Okay. So if you look at this, just one sec. So if you look at this paper, okay, it mentions 2 scales, right? It says patients entered this treatment phase of the study if they met DSM 3R criteria for delirium and scored 13 or greater than on the delirium rating scale. Okay. They've also looked at repeated assessments using the delirium rating scale, the mini mental state, and the extrapyramidal symptom rating scale. Okay, and then they have also mentioned something called, okay, they have also mentioned something called, okay, this is, okay, I'll send you this paper. Okay, there was something on, okay, there was also something called Karnofsky performance status score also that they had done. Okay, so these were the three scales that they were using. Okay, now I will now come on to the measurement part of it, right? Has anybody gone through this paper, or has anybody read through this paper? Anybody tried to read this paper? No. Okay. So basically, when I have to measure something, there are three types of measurements. Okay. One is called categorical. There are three broad scales that we do. One is categorical, second is ordinal, and the third is quantitative, which basically has either it is ratio or it is interval. Okay, now just to describe it, okay, so for example, you have nominal, okay, which is basically something which is like a category scale, right? So for example, let's say male and female. Okay, so a male and female, it is a category. There is no further analysis that you can do of it. You can't do a mean, you can't do a mode, right? There is nothing you can do except measure the frequency of, let's say, number of males and let's say number of females, but you can not calculate an average mean of the males, of the number of males. Yes, but you can't really calculate something out of it. So that is called a categorical scale or a nominal scale. Whereas an ordinal scale is something which you rate, right? So for example, you go to a restaurant, okay, and you are given a menu, right? And they will ask you in terms of, okay, do you like this better than this? So they'll give you a scale, is let's say, 1 to 5. Okay, so there is no zero. Okay, it's basically something which you measure. Now, not necessarily, I mean, even in a 1 to 5 scale, it is a rank order, but sometimes in this case that there is a difference. But let's say you have something like, let's say you have something like a Likert scale which says agree, strongly agree, neither agree nor disagree, disagree, strongly disagree. Now the difference between agree and strongly agree is only something that you know, right? How you are attaching it or how you are doing it is not very clear. Okay, so that is why we say it's ordinal, because the difference between agree and strongly agree is not something that is really very clear. Okay, so that's why it is called an ordinal scale. Now, an interval scale, you will have equal measurements, but you may not have a zero. For example, temperature. Okay, so temperature does not have a zero, right? Even in terms of zero, if let's say you have a 1 to 5, you can still use that as an interval scale because you have a 1 to 5 scale, but you not necessarily do not have a zero. Whereas in a ratio scale, okay, you will not have negative values. For example, salary, age, there is no -1, right? It always has to start with 0, right? So your age, right, let's say your BMI score, right, you will not have a negative BMI, right? It will always be a positive BMI. Okay, so those are called ratio scales where negative values are not possible. If you are doing parametric analysis, for example, when you are doing distributions, okay, and where you take a normal distribution, then you will be able to do it only with interval and ratio data. You cannot do kind of that analysis. So that is why it's all the more necessary for us to understand scales, because what kind of analysis in terms of what kind of measurements, we can only figure it out in terms of depending on the nature of the variable, only then we can figure it out. Okay, so it's important for us to understand the nature of the scale. So for example, again, as I said, for a categorical scale or a nominal scale, it's like gender. Okay, ordinal is ascending or descending. You have a interval scale, there is equal distance but there is no zero. And then you have a ratio scale. For example, you have a salary or a age or a BMI, which is basically you have a zero, you have an origin. Okay, let me just shut this off. Okay, now for example, in terms of properties, okay, so nominal, you can all categorize them. It's all possible to be categorized. So for example, let's say I say strongly agree and agree, so this is an agreement scale. Okay, right, so it is all possible to categorize them in terms of convert them into categorical variables, but not necessarily. Like for example, nominal scale will not have an order, okay, because it's male and female. Okay, right, so you can have categories of, let's say, employees. Okay, category 1, category 2, category 3, right? So if they don't have an order, then you can just categorize them that may not have an order. Distance for all the two, right? The nominal and the ordinal, you don't have a fixed distance, but in case of an interval and a ratio, okay, you definitely have a distance, right? Because there is in an interval scale, 3, 4, 5, right? So, or temperature, right? So there is an equal distance, so you do have a distance. But origin in this case is only possible in a ratio scale. Okay, let's try and do some scales, right? Okay, now for example, let's say identify the unit of observation. Okay, now what are you interested in studying? Okay, so let's say I want to study a patient. Okay, now that is my unit of observation. Okay, so first thing I have to do whenever I am trying to, let's say, find out the scale of a person, okay, or what is the unit, and then I need to figure out what is my unit of observation, right? Now it could be a patient, it could be a hospital, it can be a household, it can be a city, it can be a country, right? It can be anything under the sun. It can be even a house. Okay, it can be even a bus. Okay, it can be even an item of furniture, right? So depending on what is the observational unit, first you always start with that what is the unit of observation. Okay, the second thing is, right, what am I going to do with that observation unit? Okay, either I assign the observation unit to a category. Okay, so either I say that, okay, this bus, okay, now it can be a red color bus or a yellow color bus or a blue color bus. Okay, so either I do it as can I do it as a quality? Okay, or I measure the observation unit of some behavior, attribute or behavior. So for example, if I am taking a bus, okay, then let's say I measure the bus in terms of its, let's say, speed, or maybe its engine cc, or it's the number of passengers that it can hold, right? Then I am measuring the observation unit of some behavior or attribute. Okay, right? For an individual, it can be intelligence, it can be motivation level, right? It can be eating capacity. Similarly, for a patient, you can talk about person is healthy, not healthy, right? Sick, not sick. Okay, or depending on the patient, okay, you want to measure, let's say, hypertension, or you want to measure, let's say, diabetes levels. Okay, so in that case, okay, then you are measuring some particular attribute of that particular patient. Okay, now if you are doing it to option A and you are saying that I am going to put this in a particular, in a category, okay, then, right, for example, it has, okay, then the next thing is, am I ranking it on some quality, right? So is it, okay, is it 1, 2, 3 class, standing rank in class? So for example, if it was bus, okay, so if I was ranking it smaller, bigger, something of that sort, fine. Okay, but if I am not, okay, then the level of measurement is nominal, where I've just categorized it, okay, A category bus, B category bus, C category bus. But if I am doing it on some quality, then there's something else, right? Then if I am ranking it, then it is ordinal. For example, I say, right? So if I'm saying that speed of the bus, okay, then lower speed, medium speed, higher speed, then it is ordinal. Okay, so this is just like it's a check in terms of how you are going to determine whether the variable is nominal or ordinal. Okay, now let's say, okay, if you are saying option B, okay, measure unit on some attribute or behavior, okay, now if it has a true zero, okay, then what does it become? A ratio scale. But if it does not have a true zero, okay, if it's a measurement, but then in that case you have a uh, an interval scale, right? So for example, psychological attributes like approval, depression level, anxiety level, pain level, attitude towards life, right? So these are all, we have a measurement aspect, but they may not have a true zero, and so therefore we call them as interval scales. Okay, everybody clear with this?
Hello, ma'am.
Clear? Yeah.
Ma'am, I would just like to add with a few points, like
Okay.
in the perspective of palliative care, just for the nominal scale, we can just tell it as either pain yes or no, pain present or pain absent.
Okay.
Maybe in the ordinal scale, mild pain, moderate pain, and severe pain.
Okay.
And regarding this ratio scales, we can have a pain scores 0 to 10, like this. Is that analogy appropriate?
So it depends again on that. So if you are saying that you are categorizing people at low pain and having pain and not having pain.
Yes.
Right?
Yes, ma'am.
But you are also measuring the person on pain scales, right?
Yeah, ma'am.
Right. So wouldn't it be better if you said, right, you could categorize people as, let's say, male, female, or you could categorize people on terms of if they have, let's say you have lung cancer, let's say you have bone cancer, let's say you have liver cancer. Okay, so that would be something in terms of a nominal scale.
Okay.
Okay.
Yes, ma'am.
Whereby you have categorized them, and then you are looking at measurement.
Yeah, by the measuring the pain score. Yeah.
Yeah. So if you were looking at a pain score, okay, and it is definitely like, so if you were doing low, medium, and high, okay, then it would be an ordinal scale.
Yes, ma'am.
Okay, but if you were measuring them in terms of a pain score where you are giving explicit scores, right? So you are saying 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay,
yes.
Then yes, it's very much like a interval score, right? But
Yes.
if you were saying that, let's say you were also looking at these people in terms of, let's say, their age and weight, right? Now that would be a ratio scale.
Thank you, ma'am.
Right? Is that okay to everybody? Everybody okay with this?
Vinti, I think not okay. But that's what I see from the.
Okay, let's try and take another example. Okay, give me a
You
situation. Somebody give me a
about-
situation or a research. Let's say research variable now. Research study. Let's take a research study.
Maybe the prevalence of hypertension estimation in the.
Okay, you want to take a hypertension. Okay, and let's say let's describe. Let's do a hypothesis test. Okay, what do we want to do with hypertensive? Or let's say people who sleep for less than 8 hours a day are likely to be more hypertensive. Can we go with this hypothesis?
Yeah.
Yeah.
Right? Can we go with this? Does this make sense?
Yeah.
Yeah.
Okay.
Yes, ma'am.
So in this case, let's say I have, I do a study and I have typically like male, female. Okay. So that is, in this case, male and female will be what? Gender will be my nominal scale.
Nominal scale.
Yeah, nominal
And
scale.
let's say that the people who are coming from, let's say 2 different districts, okay, or 2 different hospitals. I'm doing this study under 2 hospitals, okay. So people coming from hospital A and people coming from hospital B, that will also be nominal, right? Now let's look at hypertension, okay. Now how do I want to do hypertension? Do I want to divide it into low, high, you have categories of hypertension?
Yeah.
Yeah.
Okay, so what are the categories of hypertension?
Pre-hypertension, mild hypertension, moderate and severe.
Border. Yeah.
Okay, so these are 5 categories. Now what are these? Can you clearly say that, you put them into a category, okay, but these are likely to be ordinal,
Ordinal.
Ordinal scale.
right? But if I were to actually, okay, let's say, what about let's say quantity of sleep? What would that variable be?
Continuous.
Interval.
It's hours of sleep, ma'am. Are you
Yeah,
mentioning
hours of sleep, yeah.
Interval score.
Ratio, it has a 0, right?
Ratio.
You can't have negative hours of sleep, right? Right? You can't have negative hours of sleep, right? So you start with 0, right? So it has an origin. Okay, so therefore it will be ratio. Right? If I were to also look at anxiety level, and I measure anxiety scores also in this study, okay, besides this, then what would that scale be?
Interval.
That will be interval.
Wouldn't that be ratio? No?
So it does not necessarily have an arbitrary 0 in this case, right? There is no such thing as a 0 anxiety level.
Okay. Um,
Everybody good with this now?
Vinti, can you show the scales?
Show the slide presentation.
Ma'am, if
Okay.
something can be categorized as mild, moderate, and severe, what kind of scale should we use for that?
So mild moderate is in terms of an ordinal scale.
Okay.
Okay. Now I'm however qualifying this also. So for example, sometimes, okay, what we do is, let's say I have age. Okay, so I may have age as a continuous variable from, let's say, 18 to 65.
Mm.
Okay, but I can convert this into a ordinal scale. Let's say I want to say 18 to 25, 25 to 35, 35 to 45, and 46 and above. So whatever age, number of age people, and whatever I done, I have converted a ratio scale into a, into an ordinal scale, right? So I have said young age income group, middle income group, right? Or let's say young income group, middle income group, higher age group, and very high senior age group, right? I have converted this into a ordinal scale, right? Or depending, I can also categorize it. So it's really up to you to figure out how you want to treat the variables. Right? So understanding the definition is important. Okay, it's very important to understand the definition, but depending on your research study, okay, you need to have these steps to figure out what you are doing. Okay, because the same variable can be categorized in different ways depending on how you are measuring it. Right, so it's important. Right, so for example, this age I have just converted from a, like, age is normally a ratio variable, but I have categorized it now. Right, so I have converted into an ordinal scale. Right, so that is what you can do. For example, when you say pain scores, now it is typically an interval score, but I say, let's say a person has got 0 to 5 or 0 to 3, it's low pain. 3 to 5, average pain. 5 to 7, high pain. 8 and above, 8 to 10, very high pain. Okay, so what have I done? I have converted into an ordinal scale. Right, everybody okay with this?
Yes, ma'am. Ma'am, can you
Okay.
please explain regarding the nominal scale, how to define that?
So nominal scale is just a category. I've just categorized it. Right. So for example, we say rural area, urban area.
Okay.
Gender is typically a categorical variable. Right. If it doesn't have a grading.
Show the slide in which.
So for example, if I have a product category, okay, and there is no qualitative aspect to it. Okay. So I put it into product category. So these are different product categories.
Okay.
Right, this is A product category, this is B product category, this is this is typical nominal scale. I haven't shared my screen, I'll just share it.
Okay. Ma'am, what about the parametric analysis in which you mentioned that the interval and the ratio data comes?
So what happens is, in a parametric analysis, anything which is, like, for example, in an ordinal scale, because it is ordinal, okay, I can't do any statistical analysis on it.
Okay.
Okay, I can't possibly do any statistical analysis on it. That is why I say that only it's only has to be a
Interval or ratio data.
yes. Okay, so for example, let's say this category, let's say this one. Okay, let's say, for example, they've taken an example of this bus. Okay, so for example, okay, let's just do it. Okay. Now let's try this. Okay, so HIV status, positive or negative? What is this? What is HIV status?
Nominal.
Nominal.
It's a nominal, right?
Nominal.
Sex, male or female?
Nominal.
Nominal.
Okay, blood pressure,
Ordinal.
stage of cancer.
Ordinal.
Ordinal.
Okay,
Ordinal.
ordinal. Okay, opinion.
Ordinal.
If I can measure it as 5 and 3, 5, I'm just saying strongly agree, agree, neutral, disagree, and I'm not assigning a number to it, okay, then I can say ordinal. Otherwise, I can use it as an interval scale. Okay, because I don't have an arbitrary 0, but there is an equal distance. The distance between 4 and 5 is also 1. The distance between 3 and 4 is also equal to 1. The distance between 2 and 3 is also 1. And distance between 1 and 2 is also 1. Okay, because I'm assigning numbers, so therefore it is a interval scale. Right? Age, what is it? Ratio. Serum cholesterol?
It's nominal.
Ratio.
I don't know. You tell me.
Ratio.
It should be ratio. What about T4 cell count?
So ratio.
Ratio.
BMI?
Ratio.
Yeah, great. Everybody's got it. Okay. So for example, if I were to investigate effect of weight gain on coronary heart disease, okay. Okay. So I would say smoker, non-smoker.
Nominal.
Current former, no. Okay. What would it be?
Nominal scale.
Nominal.
Nominal. CHD disease onset, yes or no?
Nominal.
Nominal. Family history of CHD?
Nominal.
Nominal.
Okay. Non-smoker, light smoker, moderate?
Ordinal.
Ordinal.
Excellent. Exercise regimen?
Ordinal.
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 Because
Okay.
you have not put numbers.
BMI and age? Both
Ratio.
ratio. Right? Weight? Also ratio.
Ratio.
Yeah.
Right?
Weighted age.
Yeah.
Ratio.
Yeah, this is also ratio. Right? Great. So this is what I have done. Okay. Okay. So anyway, basically this is just in terms of what are the characteristics. Okay. Accuracy and precision is like you keep on doing the same thing. You're measuring it. For example, I check my blood pressure, again I check it again I check it again. Okay. So if I keep on measuring it, the measurement does not, it's reliable, that measurement. So when we talk about a measurement instrument, right? So if I'm measuring it using some scale, right? So if I, measure, blood pressure, a machine, right? It should give me reliable measurements. Okay. Accuracy, of course, it should give me the true value. Okay. So whether I measure it by that machine or I do it by the normal blood pressure measuring machine, so the accuracy is there. Validity is supposed to be measuring what it should be measuring. Okay. And practicality is, of course, economical, convenient, and interpretable. So these are the characteristics of measurement scales. You don't have to really get into it. Okay. But this is just for the sake of theory. Okay. Okay, so quantitative research. Okay, let me just, one sec. Let me just.
And that previous slide you put, no, ma'am, accuracy, validity.
Okay.
That
You want to go to the
reliability.
previous one?
The previous slide, ma'am.
Okay, one sec. One sec. Yeah.
So
Yeah.
this concept we will use in many palliative research also, like whenever we use quality scoring or pain scoring, disability scoring or anything.
So what happens is, like, number one, when I say pain, okay, and let's say I use a scale, okay. So let's say I use this instrument, okay, is number one, that when I use this particular measurement, okay, it should measure what it should be accurately, measuring. Now, for example, like, and it's difficult to explain it in a medical context, but reliable is basically that if I measure the same thing again and again, okay, right, with other things remaining constant, the measurement should not change, right? So it's like, for example, let's say a particular doctor comes and takes my blood pressure, okay, then another doctor also comes and uses the same instrument to check my blood pressure, okay, and there is no change, then in that case, that blood pressure instrument is said to be is said to be reliable, okay, because it is giving me a consistent measurement regardless of who is doing it, right? So that is reliability. Accuracy, it measures my blood pressure correctly, okay. Validity is, for example, if I am saying something like anxiety, okay, or let's say I conduct a blood sample, and let's say my ESR is what is my normal level of ESR? 20, right? Beyond 20 is what? It's you have infection, right?
Yeah, should be less than 20.
How much? 20.
Should be less than 20, ma'am.
It should be less than 20. Okay, so if my blood pressure says, okay, it's 40, okay, now it means that, of course I've used a very simple example, but then, that test, in terms of, it actually should be able to say that it is, it is 20. Now, typically what happens is that sometimes I give my blood sample to a one particular, lab, and sometimes I give my blood sample to another one. Okay. And sometimes my thyroid test will come two different things, right? So sometimes I need to, do it again, right? And to see whether it is like consistent. Okay. Validity, on the other hand, is more in terms of, let's say, how do I describe it? Let's say anxiety, okay, or let's say intelligence. Okay. Now, how do I measure anxiety? Okay. Or how do I measure, let's say, learning disability? Or how do I measure something to do with awareness of a particular issue, or let's say knowledge of knowledge of palliative care. Okay. So when I do that, okay, I can't possibly use one measure of it. Okay. When I can't, I need couple of statements to define my construct that truly measures anxiety. Okay. If I say intelligence, okay, it's not so much as saying that, okay, this person is intelligent. How do I measure intelligence? How do I measure anxiety? Right? How do I measure pain? Right? For example, the other day, Dr. Sunil said pain is a total of spiritual, physical, there are different dimensions of pain. Okay, so pain is a construct made up of sub phenomenons. Okay, so therefore you have to, make a construct that truly measures some criterion. Okay, so I say pain, it needs to, that the measurement of that thing has to have validity in terms of being able to accurately measure what is the phenomenon of my interest. Okay, and it is not just one such variable, it may be many such statements which together kind of is able to measure pain, right? So example, if you give an intelligence score, okay, they'll ask you many questions. Okay, so for example, you had to test emotional intelligence, okay, or your EQ, emotional quotient. Don't they ask you for many questions and they give you answers, right? So for example, if anybody has done some risk-taking score, like for example, investment behavior, we typically use that, how are you, do you have a risk-averse behavior, or are you, able to take risks, right? Have anybody tried those questionnaires? Or something to do with creativity? Anybody's tried something on creativity score? Have you played any of these games on Facebook?
Yes, ma'am.
Parul has played. Okay, Parul, describe any particular.
Regarding the set of emotional intelligence, they will give
Okay.
the scenario and ask you what they will do in that situation.
Right, so all of you would have played some sort of games, and you would have realized you don't play. It's not just one question. It's a series of questions. You are given a few statements and you rate yourself. Okay, and then collectively it gives a score. Similarly, for example, we say something like a human development index or a quality of life. Right? Right now, whether that quality of life score that we have is a true, is it a valid, whether it has validity, means in the sense is whether I am measuring quality of life, right? And whether this construct of quality of life, right? Let's say if I use this, okay, and somebody independently, also somebody, there is some other score, there is also some other test, okay, and let's say I use one measure and I say my quality of life is bad, and let's say there is another score which says my quality of life. That means that both my scales are consistent. Okay, it has validity. Okay, so that is why you need to ensure that my scale has validity, and one of the reasons why, how we check it, is to test it across multiple people in multiple situations, okay, across multiple measures, and that's how you test how it is valid. Okay, so we'll not get into the technical aspects because then it becomes too complicated, but as long as you understand the basic definition, you're good.
Ma'am, but then do we have to always compare to make a test valid?
So see, in most cases, Parul, you will not be, very few cases you will be making a construct, right? Very few cases. Okay, you will not be probably making a construct. Okay.
How do you know if the test is valid then? If
No,
single
because see, validity is it's a very long process because you have to collect data. Okay, and first you kind of make, for example, let's say we do a wealth index. Okay, so I collect some data of people. Okay, and I say that okay, these are guys are really wealthy, and these are like less wealthy, these are like okay, not wealthy. Okay, I make on the basis of some of the questions that I use, and I measure it. Okay, then I go onto the ground, and then I use this measure and I use it on, let's say, another set of people. Okay, which is, let's say, my testing people.
Okay.
Okay, and then whether I see whether my results actually are true or not. Okay, so they may be classified as wealthy or not wealthy, and I should see that whether in terms of that wealthy, that whether they are wealthy, and my scores also predict the same thing.
Okay.
Okay, so that is testing it out.
Okay.
So for most cases, I mean, there will be very, the process you do an exploratory analysis and then you do a confirmatory analysis. Okay, so it's a long process. Okay, but most of us are not going to do that. We are just going to use validated scales which are being validated by somebody else, right? So for example, I can just share with you, some of these validation scales, the ones that I just, example, let's see. Now this is the score. Okay, this is a rating score. Okay, can everybody see my screen?
Yes, ma'am.
Yes,
Now
ma'am.
this is a rating scale which has been used in this, mentioned in this paper, which is a delirium rating scale. Okay, and I think the maximum score is, I think, 32 or something that you have. Okay, so here you can see they have used, now to design this construct of a delirium scale. Now these are the measures that they have used: sleep wake cycle disturbance, perceptual disturbance and hallucinations, okay, delusions, lability of affect, okay, then language, thought process abnormalities, motor agitation, motor retardation, orientation, okay, attention, short term memory, long term memory, and visuospatial ability. Okay, temporal onset of symptoms, fluctuation of symptom severity, physical disorder, right? So there are given 16 elements. Okay, and all this together make the construct of a delirium rating scale. Got this?
Yes,
This delirium rating scale is my construct. Now this is a validated scale, right? It has been tried and tested out, and therefore now it is being used. But the items that they have used is these 16 items that they have used to make this construct of delirium rating scale. Similarly, you have another one which is called this is called this is for, I think, this uh, Alzheimer's. Okay, this is a rating scale for Alzheimer's, Parkinson, dystonia. I mean, some of the terms I may not know. Okay, but again, you can see, like, they have used this rating scale and they have used this status of each symptom and rate accordingly: absent, mild, moderate, severe. Okay, Parkinson, tremor, right? So please note, right? Right. So this is a scoring sheet and this is a rating scale. Okay, and look at the items that they have used. Right, I'm happy to send you all of them. Huh? Everybody okay with this?
Yes.
How many of you use this, by the way? I mean, how many have come across this?
I haven't used them.
I mean, there is no possibility of me using it ever because I'm not a medico, right? So, but because I had done this paper, I was reading out this paper, so for your benefit, I mean, I decided to download these, research them and get these scales for you guys. I'll send them to you. Okay. Similarly, there's another one. Let me also see whether I can find that one also. Yeah. Okay, this is also. Okay, this is a general practitioner assessment of cognition. Okay. Right. So whether a person regarding their cognitive abilities.
Ma'am, the
You have not
screen is
shared anything in there.
Can you see it?
no,
No,
ma'am.
no, you have not
Okay, one
shared.
sec. Okay, one sec. Share screen. Okay, here. Okay. Can you see it now?
Yes.
Yes, ma'am.
Okay, so this is general practitioner assessment of cognition. It's a design as a GP screening tool for dementia. This was also mentioned in that paper in one of the references. It's a very quick assessment for dementia, and including you can also ask the informant also. Right. So again, this is the construct is dementia. Okay, and the items that you have used to measure dementia are this, and you have used some sort of yes and no, and you are using a score, so it becomes like it comes like an interval score. Right? Everybody okay with this now? Clear?
Thank you.
Right? I'll send all of these links to you, not an issue. Right? So you can try them on your patients or whatever, I don't know, whichever way if you want, you would like. Okay. 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 Now I'm coming back to some of the things. You can see my screen, everybody?
No.
One sec, let me see my screen. Can you see my screen now?
Yes, ma'am.
Yes.
Okay. Okay, so this is what a data table looks like. Whenever you collect data, okay, this is how you need to keep your data, right? So for example, you'll have the variables on the top row, okay, and the observations for the data in terms of the rows. So the columns are basically the names of your variables, okay, but in terms of your rows, that's how you keep your data. Okay, so each row corresponds to a observation. In each column contains information on a variable, and each cell in the table contains a value. Okay, so for example, you will have, this is a typical example of a variable in a data set which is a statistical data set in one of the thing, which is either, I think either it could be Stata or SPSS, which of the two, right? So that's how you would see the data table in a statistical data set. Okay, right? And they would typically define that, okay, what is SIG 1930? It is per capita cigarette use, and then mortality is lung cancer mortality per 100,000 in 1950. Okay, so this is how the data set is constructed. Okay, and the unit of observation is the region, not an individual. Okay, so you do this. Now these are basically scaling techniques. We can just sort of compare, okay, and just have a run through it. They can be either comparative scales or they can be non-comparative scales. Okay, so I just very quick ones. Comparative scales is like you are comparing, one person. For example, you would compare, let's say you've got 5 brands of soaps, and you would compare, okay, that, okay, if I, let's say on smell, okay, so whether this soap is better than this one. So you would have some, some attributes, and you would kind of measure them, and then depending on that you would either rank them or on some attribute or something. Whereas in a non-comparative scale, you don't scale, you don't necessarily kind of measure them, comparing them to somebody. You would just rank them independently. So somebody comes, to your clinic, okay, or to your hospital, you just measure what is their pain, but you don't exactly compare two patients at the same time and say that, okay, is your pain more than this one's pain? No, you don't do that, right? So that is a non-comparative scale. Okay, now let's just, I won't get into this because this is pure theory. Okay, now in a paired comparison, okay, it's usually ordinal by nature. Okay, and you will obviously, the number of comparisons, if you have n brands, then it will be n minus 1 divided by paired comparisons. Okay, you can convert it into a rank order, but it's kind of difficult. Okay, so for example, you have this, so you have this brand, okay, this is a toothpaste, it's a rank order, so you will rank whether I like Colgate, Gleam, Sensodyne. Now it's like typically, okay, I want to go for a medical treatment for maybe get an eye test. Okay, so I have 5 options. I can rank, okay, this clinic, that doctor or something. So I can do that rank ordering where I compare the physician or the medical establishment. So that is one example where you use a rank order. Okay, and I'm comparing one facility to the other. Okay, and a constant sum scaling is that let's say I give 100 units. Okay, and I say that if you had to divide this sum of sum to attributes of a particular thing. So let's say okay, let's try this. Okay, let me just open an Excel sheet. Everybody can see my screen? Yeah. So I have hospital A, I have hospital B, I have hospital C, right? Or let's say I have a palliative unit. Okay, I have it in a hospital, I have it in a community nursing home.
Ma'am, we cannot see your Excel sheet.
You can't. Okay, let me share again. Can you see it now?
Okay.
Okay. So can you tell me the different kinds of settings of a palliative care unit?
Yeah, hospice, hospitals,
Hospital. Okay. Then next,
hospice,
hospice, and
Nursing homes.
Nursing homes,
Home care.
home care. Okay. Oh, yeah. Okay. Anything else? Okay. Now let's look at the attributes. What are the attributes when you say quality of palliative care? What were the attributes?
Pain relief.
Pain relief. Okay. Okay. What else?
Physical symptom relief, psychological
Physical,
relief,
physical
physical relief
relief.
of the
Okay. Okay.
psychological relief,
Psychological relief.
social and financial relief, spiritual
Financial.
relief,
Social.
social and financial,
Social relief.
social and financial.
Social relief. Okay. I just put it financial relief. Financial
Number
burden.
of patients.
Caregiver relief.
Caregiver relief. Okay. Okay, let's say these are these 5 attributes. Okay. Okay. Now I have 100 units that I can divide, okay, across hospital, across hospice, again nursing homes and home care. Okay. Now let's say I have for pain relief. Okay. How many points out of for hospital I want to do pain relief? Anybody can give me anything.
I couldn't understand your.
We would expect all patients to get pain relief.
No. I am saying, for example, if I had to compare a hospital to a hospice to a nursing home to home care, and I want to compare it in terms of, let's say, the ability to bring pain relief.
Then hospital can bring you about 100% pain relief.
Yeah, but now in this case, I want to compare this in this respect. So one way I could do is a rating. Let's say I give 5 to this, 4 to this, 3 to this, and 1 to this. Okay, this is one way of doing this because I have compared it. Okay, the other way to do this is, okay, and it's not a very popular scale, but let's say the patient is given 100 rupees or 100 units. Okay, and I ask the patient that, okay, with regard to a hospital, okay, if I go to this, right, I have suppose in this I want to divide in terms of the relief this. So it's like a rating scale. I may give 50 out here. Caregiver relief is just 20. Okay. Psychological relief is only 20. Right. Financial burden is again just 10. Okay. Social relief is okay, maybe 15. Okay. So I have 50, 70. Okay. This is like, let's say this is 5. Okay. 35, 40, 60. Okay. This is 40. Okay. 60, 80. This is 10. And this is 5. Right? Now let's say I have done this there. Now here in this case, okay, maybe my physical relief may be higher out here. Okay. My caregiver relief may be 30 out here. My financial burden in terms of giving higher points out here, right? And similarly, I can do this. Right? It's basically giving a sum of money and kind of, a sum of points. It's like, say, okay, I want to distribute it. Okay, so that is basically what is called a sum of points. Okay, this is a typical scale that we use, not often used, but yes. Okay, but let's say, for example, if I want to say
weightage, ma'am,
it's like a weightage. Yes, absolutely.
but the absolute number total should be like 100 only.
Yeah, right. So for example, this is an example. Can you see this?
Yeah.
Right. So segment 1, segment 2, segment 3. So I have done this. Right now, a person is assigned points to all these 3 segments. So here in this case, I have done it in a bathing soap, but you can do it for various facilities also, right? Now, because this requires a little bit of an effort, okay, probably a patient may not be doing it, but let's say if you as a more informed person, and let's say there are 10 people in the room, and you were given this exercise of really comparing the quality of palliative care, and you identify all these segments and the attributes, you would probably do it, and then you take out an average, then you will be able to compare and see what the average scores, right? So when you calculate and do the mean of it, then you will actually be able to compare which segment scores on what, taking let's say 10 responses or 20 responses on that score, right? Got it, everybody?
Yes, ma'am.
Okay, now this is a continuous rating scale. Okay, so you have a semantic is probably the worst and probably the best, okay, but there is no numbers out here. Okay, in this case, right, you have given probably the worst and probably the best, okay, but you have been given some numbers in between. In this version 3, okay, you've again got probably the worst and bad, but here also you have qualified that very bad means.
Sorry
Okay.
to interrupt, ma'am, but we are still seeing your Excel if you are trying to
Okay.
share something.
Okay, one sec. I think there's a problem, once you do it, it just becomes.
It's some update with the Zoom, I guess, because in previous sessions also faculties were finding the same difficulties.
Because I am just sharing and I am assuming that it is being shared.
Yes, sir, no worries.
Okay, one sec. Okay, this is where we were. Okay, this is the constant sum scale. Okay, for example, I talked about those 100 units. Now in this case, it's a bathing soap. Right, you can see the 100 points are divided among mildness, lather, shrinkage, price, fragrance, packaging, moisturizing, cleaning powder. Okay, I did it on an Excel scale in terms of the different facilities of your palliative units, and I've defined the attributes in terms of the different kinds of relief that you can give: financial, social, physical, psychological, emotional, spiritual. Okay, and then you would kind of, let's say you would had 10 people in the room, right? Each of them were given the sheet, and each of them would then divide those 100 points for each of the 5 segments that you had, and if you would average out the scores, you would know that which one scores more and which one scores less, right? Is this okay? Does it work?
Yes, ma'am.
Okay, do you see possibilities of doing this in your day-to-day work?
Yes, ma'am. Yeah. In paints course, I think we can.
Yes, you can do this. Okay, now when I do continuous rating scale, now this is a rating scale. Okay, you have one rating scale which says you have, let's say, probably the worst and probably the best, but here I have not put anything in between. Okay, now this doesn't work anything because the person is unclear. In the second one, I have given 10, 20, 30, 40, 50, but I have only identified worst is 0 to 20 and best is maybe from 90 to 100. Okay, in the version 3, if you note, right, I have given the maybe not drawn properly, but in between also I have defined the scales. Okay, so it's easier for a person, if it's a patient, it's easier for a person if you're doing it and you give them the scores, he knows exactly, okay, 30 is bad, or 50 is neither good nor bad, right? 60 is good, right? But it's 100 and 90 or 100 is probably the best. Okay,
Our VAS score is dependent, I think, on the continuous one. The VAS score which we use for the pain assessment.
okay. This is a typical Likert scale. Now, Likert scale, normally we say strongly disagree. See, Likert scale is any 5-point scale. It can be a 7-point scale also. It can be a 3-point scale also. It can be a 4-point scale also. Okay, it can be very helpful. It can be useful, right? It can be high. Okay, so you have, very low, low, medium, high, very high. Okay, that is also a Likert scale. Okay, it can be very poor, poor. Okay, neither poor nor good, good, very good, right? Even that is a Likert scale. Okay, and you can definitely put in brackets, the scores that you want to assign, because once the person, so then you can convert it to an interval scale. The advantage of a Likert scale, and you assign scores to it, you can if you have multiple statements, okay, then you can add up the scores, and then it becomes like a continuous variable or a score, which you can use to do some statistical analysis. Okay, shall we do a small test, or you want to play a small game on this?
Yes, ma'am.
Okay. Let me open a Google Sheet. Okay, let me see. Just give me a second. I'm just trying to figure how to ensure that you guys just give me a second, okay? To do on a Likert scale.
Ma'am, if you want sample questions, I believe our normal feedbacks regarding every sessions is based on that only, like these
Okay.
parameters: strongly, disagree, agree. So if you want, maybe I can share a couple of questionnaires in the chat, which you can take up.
You can do that also. I was just doing one, so let me just
Like overall satisfaction, all these.
hospitals. Okay.
The service assessment following a counseling or a
Yeah,
community.
anything on that set, right? That's anything can work on that, right? It can be any particular right. So I was trying to look at, let's say, palliative care. For example, palliative care should be made mandatory for all hospitals, right? So everybody would say strongly agree, right? It should be made mandatory for all nursing homes, right? So people may say, okay, agree, okay, something on that sort, right? Or palliative care education should be there for every oncologist. Okay, so you can have a rating scale on that. Okay, or the understanding of end of life care, should be a compulsory course for for every student in master in social work, right? Something on that sort, right? So you can use anything as a Likert scale, and once you kind of add the scores, and let's say you have many observations. Okay, let's say I have all of you people and you have all the observations, and I average it out, then the entire total number of scores becomes something that you can analyze, right? It can be used in statistical analysis. That's what I'm trying to kind of say. Okay, let me just get on to the others. Screen. Okay, so let's finish this. Okay, this, everybody can see my screen. Everybody can see the screen.
Yes, ma'am.
Okay, this is a semantic differential scale, okay, which is an opposites
Yes.
scale. Okay, this is a staple scale, which is a unipolar rating scale, which has a plus and a minus also. Okay, it is -5 to +5. It can be, this is an example, it is, but it has both plus and minus. Okay. Okay, and right, so you can have number of categories. It can be 5 to 9. Okay, it can be balanced, it can be an unbalanced. For example, if you have a 5-point scale, it is a balanced scale, but you can have an unbalanced scale, let's say 1 2 3 4. Okay, so that's an unbalanced scale. Okay, because it's you says let's say you say average, medium, good, very good, excellent, right? It's not exactly a balance because you don't have a negative part of it. Okay. Similarly, number of categories. Okay, you can have a neutral scale, you may not have a neutral scale. Somebody says can't say, do not want to answer, but non-applicable. So sometimes we don't use that can be right. So we don't, sometimes when we say, we don't give the option to a participant to do that. So that is a fault scale, because some people may be having an option of not share, not sure, do not want to answer. Okay, so that is sometimes a force scale, whereby we force a person that even if he has a neutral or does not want to answer, we force a person to answer. Okay. Okay, I will not get into this. Okay, now these are some of the pain scales that I kind of worked out. Okay, these are pain scales. Okay, this is a pain scale for people who can't express, who can't say. Okay, this is for babies. This is a comfort pain scale. Okay, again, this is a pain scale, and again you can see the items. Okay, this is a Mankovi's pain scale. Okay, this is a brief pain inventory. Okay, so this is, again, you have questions and you can see the scale 0 to 10. Okay, and once I add up all the scores, okay, I will get a total number. Okay, and let's say I have 100 people taking this brief pain inventory, and each of them will have a total score. Okay, that will be 100 observations and 100 total pain scores, and which I can subject to some sort of analysis depending on the nature of disease that they have. Okay, now we'll do qualitative and quantitative methods. Anybody's tried qualitative and quantitative methods? Anybody?
Yes, ma'am. Some quantitative methods I have tried.
Okay, what about qualitative?
Qualitative, I had some exposure, but I don't have done a research based on qualitative methods.
Okay, anybody else?
Most of our thesis and all is for quantitative only, ma'am.
Quantitative. Okay, so nowadays yeah,
Indeed, I have done a qualitative analysis in paraplegics about their attitudes and their views on sexuality.
but did you rate them or did you just carry out a conversation?
I carried out a conversation.
Okay, okay, and then did you code it? Did you were you able to take out some constructs in terms of based on what they said, right? Were you able to do a thematic analysis? Okay, let's try this. Share screen. Okay. So the first thing you have to do is basically Dr. Sunil, I can't hear you.
So, sir, sorry, but your voice is very much lagging.
Okay, so in a research design, okay, you can use qualitative research, you can use quantitative research, and you can use both. Right? That is called a mixed method research. Okay, much of it depends on what is your research goal, what is your number of participants, what is your research question. Okay, how important is theory? Okay, if you have a theory, sometimes in qualitative research you don't necessarily need a theory, right? You can just go to the field, and based on your field research, you can formulate a theory. Of course, literature review is great. Okay, but qualitative research not necessarily does not need to have it's good to have a hypothesis, but sometimes in qualitative research you can still do without a hypothesis. Okay, so in qualitative research, it is also called a process evaluation. Okay, so it is on the processes and the qualities of the entities that are studied, whereas quantitative research is more with systematic and scientific investigation of quantitative properties and their settings. Mixed method is integrating both qualitative and quantitative. Okay, now in a qualitative method, may or may not have a hypothesis, as I've already explained, and would depend on the researcher and the phenomenon under study. There is always a relationship between the researched and the researcher, because the researcher, while interviewing the subject, is very much involved doing it, right? It is when the participant is saying something, there is something that is being said. It is either some opinion, some feeling, some thought process, some attitude, some behavior. So all of it is being observed and being recorded by the researcher. Of course, you need to be honest, but it is still going to be a little subjective, because ultimately the researcher will have his or her freedom of opinion as to how it is to be interpreted. So there is a context to the entire thing. Now most of the time, we do a thematic analysis or we do some coding of the qualitative research. Now I am sure some of you may have heard of this kind called a focus group discussion. There is something called in-depth interview and a key informant. In-depth interview can be for anybody, like anybody who has a reasonable knowledge, but a key informant is somebody who has really good knowledge of that particular subject. Then role play is you put a person into that situation, you imagine, ask the participant to imagine yourself in that situation, and then see how that person is going to react, right? What is it that comes to the fore? Projective techniques are like, let's do a small let's say I give you a word of pain. Can each one of you just when I say pain, what is the first word that comes to you? You can type it on the chat box also.
Suffering.
Okay, can everybody chat it on the chat box, please? Let's try it. Okay, so we have some very interesting observations. So when I said pain, so agony, quality of life, suffering, unbearable suffering, limitation of functions, medicines, depression, isolation, disturbed sleep, anxiety, fear, financial problems, fatigue, angry, judgment, loss of appetite, disturbance. This is a word, you kind of associate things. So now let's say, right? Let's try and complete this is like a word association. Now let's try to complete a sentence. Research in palliative care. Okay, let's type this. Research in palliative care. Let's complete the sentence. Let's complete the sentence of research in palliative care. Okay, so this we just had a very great, variety of perspectives. Okay, but you can well imagine. Okay, so is lacking, is need of the hour, is mostly from high income countries, needs funding, should support policy making, not done as usual because of the specific patient population, low socioeconomic group, will add knowledge about the treatment in UL care, is must to bring awareness and new policies, mostly occurs in Western countries, needs team effort, will enhance the quality of life of patients, should inform policy, uh, end of life care is enhanced, will become more important in low income countries. Fantastic. Right? Can you see the results right now? Anybody seen what happened just right now?
Yeah,
We
the
are how
opinions
many?
are just different.
We have everybody's perspective is different, but collectively, look what has happened, right? With all this 16 members out here, right? We have brought amazing range of responses, and we've identified what issues are there, right? Similarly, if I show you as a thematic, is let's say, suppose I kind of give you give you a picture, okay, or a movie, right? And everybody's sees the same movie, okay. And let's say you show this patient this movie about how palliative care is done in, let's say, in Kerala, okay. And you show this movie in different settings. You make a movie and you show it in different settings how palliative care is done in there, and then you ask the patient to write his or her observations about what kind of care does he or she want. Right? Now let's say, right, I ask a statement, and there's another in this kind of an expression. Right? Let's say I ask a statement, what do you think about palliative care? Okay, somebody will say X. Then I qualify this question and says, what do you think about palliative care if you had very little money, you had only 15 days to live? Okay, then what would you say? Would there be a difference in response?
Yes, they will.
Right? So that is the way you kind of, sort of get something out of a person. It's also it's a qualitative technique, but this is great, right? You will get a sense of perspective. Okay. Yes, it is. Yes, Dr. Raman, it is a good qualitative research tool, right? Because when you interview many participants, okay, and you use these tests as a methodology, you will get perspectives.
So we usually get these statements and we do the thematic study,
Yes.
and draw
Yeah.
our conclusions with that.
Yeah. So normally what we do is normally interviews, right? Right. But I am saying, right, for example, I remember doing a study. Okay. Of course, I wrote half the paper, but I never got around to publishing it. I remember when we were doing COVID and we were, asking, teachers what they really thought about the quality of learning in terms of, when you are doing it in a digital versus, this thing, or pre-COVID and post-COVID. So we gave them metrics. Okay. And we said, okay, quality, concentration, learning. Okay. We gave them words. Okay. And then they had to immediately respond. Okay. So it really provided for a, sort of diversity in what really brings out, in a person, what is going on in a person's mind, because you are just given them that split second to, respond. So it just gives you a very,
Uniformity in the.
yeah, very natural response without somebody being very rehearsed about it. It is a tool that can be used, depending, of course, on the methodology that you want to do. Okay, so this is qualitative. Okay, then this is. Okay, this is a quantitative method. This is a qualitative method, and this is a okay. So in a qualitative method, a data collection analysis, it kind of takes in parallel, because at the same time you are taking something, and sometimes you are, already mentally you are already you're doing some analysis at the back end. In your mind you are doing something, and of course you do transcribe it and you again do it. But yeah. Okay. Quantitative, again, correlation does not imply causation. Okay. Mostly you are doing some kind of, relationship. Of course, if you were doing an RCT, random control trial, then you can still try and do attribution. Okay. But causation, otherwise, for most purposes, you don't have causation. Okay. So basically, in quantitative method, you try and look for the nature and the intensity of the relationship. Usually it is less biased, because you are not the researcher is generally not collecting the data. You normally give it to a, to an organization, and you train them to be objective. Okay. So data collection methods are, structured interviews, maybe schedules or questionnaires or something of that sort, and mostly there are close-ended options. Okay. And before you do a survey, you typically, pilot test it. Okay. And you need to have a representative sample. Okay. Mixed methods is both qualitative and quantitative, so you're using both, in an inductive and a deductive approach. Okay. In an inductive approach, you have, specific observation. You look at the patterns and then you come at a conclusion. Whereas in a deductive, you already have a theory, you formulate a hypothesis, and you collect data, and then you either approve, so qualitative is usually inductive methodology, whereas quantitative is usually deductive methodology. So qualitative is, you are looking at something. Okay. You look at observations, you find something, there is a pattern. Okay. You come to an observation. Of course, you can always, once you have formulated something, then you can always use a combination of an inductive and a deductive approach also. Okay, so that's also possible. Okay, so survey, all of this is these are just the pros and cons. Okay. And in survey method, you may not have the respondents to respond. Okay, sample selection can always be a problem. Okay, and if it's complex social issues, then survey research may not be suitable for that. Okay, and such focus group is like you have 8 to 10 members and you have a moderator. So you'll have 8 to 10 people and there will be a moderator, and you will typically, like, it's like a group discussion. So you ask one question and you have different perspectives and different people saying something. You moderate the discussion, then you'll ask another question, and then you try and identify common points and points of disagreement. So the idea is to have some sense of understanding of what the situation on the ground is, what are their impressions, what are their feelings, what are their likes, dislikes, what are their opinions, okay, how they react to a particular intervention or a product or a service, right? So the idea is that you still have to have a discussion guide, because you never go to a focus group without having a discussion. You need to have some sort of an instrument which at least broadly discusses what is it that you want to talk about. Okay, and you do collect some basic demographic information like name, age, locality, the date at which it is done, maybe some categories of the respondents, okay, depending again on the intervention. So this is what you have. Primary data panels are basically they are like focus groups. Okay, panel data is basically you ask them some information, but then over a period of time you may use the same members, and they kind of you go to them on various phases of study. Okay, so static, they can be either static, which means the same panel members are there at different phases of the study, whereas dynamic is the panel members might change over a period of time as various phases of the study are in progress. Okay, so basically if you want to kind of look at an intervention over a, let's say, 1 year period, so you may recruit certain members, you may have a discussion, then after 3 months you go back to the same panel and then again ask how's it working, then again after 3 months you ask the same group how's it working. So you get a historical perspective of how the intervention has panned out or the project has panned out from the eyes of the same members that are part of the panel. Okay, unobtrusive methods are like, for example, you're not asking people, but you are just observing something, right? So you go to a place, you see, for example, if a book is being used many times, it'll be little worn out. But if you see, you go to a place, say that you don't see, go to a hospital, you see the sheets are absolutely tidy, everybody is very immaculate, and you finally feel that probably the hospital is not used much. Okay, so that is an example of an unobtrusive method. So it can be any variables, any kind of metric that you may look at. Okay, so it can be field settings, it can be lab settings, you can have interviews, you can have telephone interviews, you can have computer assisted, for example, what is called CATI, computer assisted telephone interview. Okay, you can have questionnaires that are personally interviewed, you can have email questionnaires, you can have physical questionnaires, you can have observations, you can have recordings. Okay, so there are many methods of collecting data. Okay, I hope the session was not too much today for you.
No, ma'am, it was good actually.
Vinti, there are some questions in the chat.
Yeah, I am just looking at that. I'm just trying to look at that. Okay, one sec. Okay. Okay, I answered this. So I think for the end of life choices and spiritual advice, we can give words and complete their sentences to understand their ideas? Yes, definitely you can try it as one methodology, right? How people relate to death, right? Let's try this. We can try this. Now, what is the, if I say the word death, what does it sound like to you? Okay, so you can always use that, okay, to understand people's attitudes towards death. Okay. Um, okay. When you use word association or sentence completion as a qualitative technique in place of idea and FGD, how do you code or just summarize? You can still do a frequency. Okay, you can depending on the words that are used, you can do a thematic analysis. Okay, that is possible. So you can definitely do coding. How should we do coding and thematic analysis to find recurring thing? Are there reference, or there are a lot of qualitative books, qualitative methodologies that you will probably have, and that's a that's a separate study in itself. Okay. Did we use a focus group method in faculty development program, Dr. Sunil?
I'm not sure.
Yes, I had answered that question. So
Yeah. Okay. Okay. Yes. Okay. Focus group is qualitative. It's not a quantitative method. Right? Any other questions? From next week, we'll start with more with things like probability distributions, right? So
Ma'am,
right now, yeah.
just now you mentioned that we can see the end of multiply, like what the word death means to you. Like if we get the answers, how we are going to conclude the qualitative study of death meaning?
So I don't know in terms of how you want to use it, because at the end of the day, you, let's say you want to do a work. What is it first that you want to do, Parul, in terms of, let's say, death, attitudes towards death?
Uh, cultural impact. Uh,
Maybe if we want to know where do people want to die, at hospital or hospice or at home.
Okay. So you can ask them to do a visualization exercise in terms of, how imagine yourself in terms of, if you were end of life, in what is the thing that you would, that you would, how would you like to be taken care of? Right? So let's say you kind of did that, and let's say you are some 20, 30 people in a particular setting. Okay. And you would be able to get a sense of how people want to be, how they react towards death, and how they want to prepare for death.
Basically, we have to infer from the statement.
Yes, infer from the statements. You have to do a thematic, what are the themes that will come out. So for example, we did palliative research, palliative research. So what are the themes that came out? Expensive,
Not done in the low socioeconomic.
not done in socioeconomic centers. It's mostly a Western phenomenon.
Need
right?
funding.
Lack of resources. Right? So now, even within this, okay, lack of resources. Now, Kavin might have said it in a different way. Okay, Dr. Sunil might have said it in a different way. Parul might have said it in a different way. Okay, so everybody has, even in some things and lower resources, maybe a common theme is coming, but even in that low resources, you would still tend to qualify that low resources in terms of what? It could be financial, it can be statistical tools, it can be in terms of knowledge. Right? So there are so many within that broad theme. There could be so many other things that would come. Right? So if you're talking about death, so they could, one talk about anxiety. Okay, they would talk about fear of death. They would be in terms of pain. They would be in terms of making adequate preparations, before making your life and your financial affairs. Right? Right, to me in terms of exactly at that moment of death, how do you want to, which, whether you want your family members around you, or you're okay dying with a hospital. Okay, it could be anything.
Okay, ma'am.
So you'd have to identify themes for this.
Okay.
How to overcome the language problems when we are doing a qualitative study?
Very difficult question. Okay, very, very difficult question, because I struggle with this. Because see, right now I am doing a study which is spread across 6 states. Okay, so the first thing that I have to do is I make sure that I translate all the questionnaires in the respective language. I never ever, if the participants' language is Tamil or Telugu or Malayalam or Marathi, I make sure that I translate in the local language. Okay, because the nuances of language are very important. Okay, now I'll give you a simple example. Okay, for example, menstruation. Okay, which states are you from?
Jammu.
Okay,
Tamil Nadu.
okay. Anybody from any other state? Kerala. Okay. Okay, okay. Let's just say the person has expired. Okay, very simple. Okay, let's say in Kashmir, Parul, how would you say convey to a person that the person has died? Say it in Kashmiri and then and translate it back into English.
Chon mol chumud mut. It is in Kashmiri.
Okay, and what do you say? Now translate it back into English.
It means their father is no more.
Okay, okay. Let's try. Dr. Sunil, convey death. Convey a message of death.
അച്ഛൻ മരിച്ചുപോയി.
Okay. Now convert it back into English.
Son is murdered.
Father died.
Okay. Anybody wants to try in Tamil?
There are many words, ma'am. We can tell அப்பா தவறிட்டாங்க, அப்பா காலமாயிட்டாங்க, அப்பா இறந்துட்டாங்க.
Exactly. That's what I'm trying to tell you. It is the nuances are so important. Community specific. There can be within the same state, different localities, different ways to do it. Right? I remember doing a questionnaire on menstruation. Even for the word menstruation, I had to really, look at the word which conveys it in that particular state. Right? If you ask, and I'm sure I mean, as I'm not a doctor, I just come from a doctor. When you ask for a diagnosis, okay, in different settings, different states, different social cultural, you will probably have to ask it in different ways. Right? For example, if you had to person, do you drink regularly? Right? Now, Imagine you had a rich patient. You imagine you had a female patient. Imagine you had a, person from a lower socioeconomic category. Would you change your language?
Yes, ma'am, we have definitely changed.
And so that's why I said it's a very, very difficult session. Yes, Dr. Sunil is saying we have to end the discussion, so we'll end it right now. Thank you, everybody. Right, I hope you had a great time.
Yeah, I think we have also the time. It's going to be 8:50. So today we learned about uh, various scales, um, measurements, and construct variables, measurements, and we talked about ordinals, nominals, ratios, intervals, and qualitative and quantitative analysis. And in qualitative analysis, talked about many methods, focus group discussion, in-depth interviews, thematic analysis. So I'm sure we have to read many times to understand these things. And if possible, read it tomorrow itself. Otherwise, we won't remember. So thank you, Vinti, again for being our faculty for today's session. Thank you.
Thank you.
Shukriya, it's over to you.
Thank you, Dr. Vinti. Actually, I was just starting to enjoy the discussions when it came to conveying messages on different languages, but then I felt that it ended so soon. See you in the next session. And with a gentle reminder that, dear fellows, we are going to shift to the next year very soon because we'll be starting with our advanced sessions, the self-learning modules very soon. This is Sri Priya along Dr. Vinti Agarwal and Dr. Sunil Kumar signing off from the Palim India's desk. See you in the next session. Till then, everyone, take care. Bye-bye.
Bye.